So the next one would be Dr. Ali Babelli. The first exposure I had with him was in Khubar, I believe, in the first neuromuscular conference in Saudi Arabia. And I was amused about his talk. I think, if I'm not mistaken, you were talking about channelopathies. Dr. Ali Babelli is a consultant neurologist in Dalla Hospital in Kingdom of Saudi Arabia. He had his Jordanian board qualified, and he has neurophysiology fellowship in Prince Sultan Military Hospital. Today, he will be talking us and amusing us on updates on CIDP. Dr. Ismail, go ahead.
Where is the, okay, so I cannot see it from here. Assalamu alaikum wa rahmatullah. First of all, I'd like to thank everybody for this opportunity, and especially Dr. Suhail and Dr. Abu Bakr for their trust, and for you all for your trust. Before we go to the end of the talk, to scratch the head, to drop everything, I can give you an allowance of sleep now, if you can, but within the talk, I will wake you up for some important things. So, so this will reflect here. So in this talk, I'll go for updates on CIDP. I'll go for some junior talks and points, and I'll go for some advanced one. I'll go for introduction, then I'll speak about epidemiology, some pathogenesis. Oops, what happened? Clinical features, diagnostic evaluation, therapy, and we'll speak very briefly on special considerations, then on prognosis. Now, as introduction, this is for juniors mainly. What is CIDP? CIDP is acquired immune-mediated neuropathy. It is affecting peripheral nerves and nerve roots. And clinically, you should think of symmetrical or asymmetrical, distal and proximal, or distal or proximal, motor more than sensory, motor with sensory, sensory without motor. Patients will have paresthesia usually, and don't forget the reflexes and fatigue. It would be chronic, 2 months and more, relapsing, remitting, or progressive, like multiple sclerosis. It should respond to steroid, and eventually you will have demyelinating pattern either in neurophysiology or in pathology. So, unfortunately, the guidelines are really old. So the European guidelines, which has been published in 2010, had lots of updates after this. And we have another guidelines published in 2013 in Japan, and I leave it for people who can read Japanese. Since then, we really had some advances which can really make a change in our practice, but still the advances in the guidelines are not shown yet, unfortunately. So the jump is very slow. Okay, so what about epidemiology? This is all the statistics. In the past, in the era of the guidelines, which is just 10 years ago or 13 years ago, we had the confusing statistics. Is it 0.8 to 100K in population, or is it 8.9 cases? And this probably is because of the diversification of diagnostic criteria and the efforts of studying the epidemiology. But we have very recent study published in 2019, ended in 2017. It is a systemic review over 907 studies. They found that the incidence is 0.33 per 100K, and the prevalence is 2.8 per 100K. And they found that CIDP is primarily affecting adults, and we know this before their study. And they found that the males are affected more than females with ratio of 4 to 1.5. So what about pathogenesis? What can cause CIDP? CIDP will be definitely a reflection of T cell activation, so cellular immunity is playing a role. There is also humoral immunity activation because immunoglobulins and complements are playing a role. And also we have no clear trigger so far. There is some reports that the same trigger of Guillain-Barré syndrome, for example, the Campylobacter, can trigger CIDP, but this is not as clear as can trigger CIDP, but not as clear as GBS. Now, this is very important for juniors. This is common question in exam, and this also will help you to understand the CIDP. The CIDP shows segmental demyelination. It is not diffuse demyelination. With demyelination and remyelination, will have something called onion bulb formation, and this will make the nerve swollen or thickened. Sometimes the nerve of CIDP will be double or more than double the size of the normal nerve. And this will help us in diagnosis significantly in some confusing cases. We'll come to it later on. So the nerve involvement is patchy, unequal involvement, and the demyelination tends to happen around the node of Ramvirz. And this is very important also. We'll come to it immediately. Take some breathe and concentrate here. Nodal and paranodal antibodies have been discovered that it has very important role in pathogenesis. We found about 10% of CIDP patients with nodal and paranodal antibodies against proteins in the node of Ramvirz, neurophysin and contactin 1 specifically. So they are IgG4 subclass antibodies, and the pathogenesis of the neuropathy in these patients appear to be distinct from the regular autoimmune neuropathy. So, and this is not only important because of this new understanding. This is really new, not more than 6-7 years, and the recent discoveries and confirmations are just 3-4 years. The importance of this discovery that those 10% population of CIDP tend to have significant refractory to IVIG. And they need a very different management plan. We'll speak about it very soon. So this is neurophacine and contactine 1 is exam question, guys. So what are the clinical features? We have classical CIDP and we have non-classical, typical CIDP and non-typical. The typical is the most common, which is 50 to 60%. And simply you can memorize typical CIDP by just, everything is symmetrical. Everything is symmetrical. Symmetrical right and left, symmetrical up and down, symmetrical proximal and distal. There is no preference in weakness distribution. The motor involvement is more than sensory. It is usually progressive, and this is the majority of the classical, of the typical CIDP. Some of them are relapsing remitting, and we don't have significant autonomic dysfunction. So just remember that vast majority of CIDP is just as if you are blowing whole the nerves of the body of the patient. Okay, so no asymmetry. Now this is the typical. We have the atypical, the variants, CIDP variants. We have 7 variants of CIDP. Okay, it is not moving. Okay, this is not complicated table. Don't worry about it. This table, if you can take a picture of it, this will simplify probably a chapter, and this is very, very important. We know now that 50 to 60% of CIDP is symmetrical. 5 to 10%, this is the most common type of CIDP, is asymmetrical, what we call multifocal. Okay? The multifocal pattern, it is demyelination. We call it multifocal acquired demyelinating sensory and motor neuropathy. المدام حتى ما تنسونها. Okay? is following you wherever. Multifocal. Okay? So just add S in the middle. Okay? This pattern is confused usually with neuromyelitis multiplex. Okay? The only difference between them, or not, I shouldn't say the only difference, the major difference between them, that this asymmetrical Lewis-Summer syndrome is demyelinating, while that is axonal. And this will be differentiated by nerve conduction study and EMG. Okay? The second most common is not the sensory dominant, not the distal sensory dominant, not the proximal, not the pure motor, the 2 IgG4 induced, the neurophacine antibody mediated and the contactine 1 antibody mediated, which we are knowing more and more nowadays. The sensory predominant is exactly the same as the symmetrical pattern CIDP, but without motor. It is very diffuse. Everything is symmetrical, right, left, up and down, and proximal and distal. But the difference is that it is mainly sensory. Even if nerve conduction EMG showed some motor changes, but those changes are not really reflected to the patient complaint. Usually they don't have weakness. The other pattern is distal and sensory predominant. And the difference between the diffuse sensory, the sensory predominant, and this one is that this will mimic the picture of the diabetic neuropathy. It will be distal in hands, distal in legs. But more important than diabetic neuropathy is the presence of anti-MAG antibodies. So this, if there is anti-MAG antibodies, this will make it out from the CIDP. It is not anymore CIDP. The management is different, the etiology is different, so it is completely different than CIDP. So you should think about monoclonal gammopathy of clinical significance and Wallenderstrom macroglobulinemia. This usually more slowly progressive. The fourth one is proximal polyradiculopathy, and this is very tricky, very, very extremely tricky. This can be sensory radiculopathy, can be motor radiculopathy. The thing that when you do nerve conduction study, it will be normal. And the patient has CIDP. How can this happen? Because the involvement is pre-ganglionic. This is exam question. Okay? This is a real exam question. The involvement is pre-ganglionic, so the ganglion is intact, so the axons post-ganglion and the myelin post-ganglion are intact. So the conduction will be completely normal, even if the nerve is 100% damaged. Okay? So in this situation, we cannot really depend on nerve conduction EMG. We need MRI. We need somatosensory evoke potential to evoke a response and get it recorded centrally for the central guys. Okay? And we need CSF to measure the protein because it is radiculopathy. It's near the CSF. So the pure motor is again very tricky. It's extremely rare. I saw one case. The patient here will be confused as ALS. And this is very important. ALS is untreatable. And this is completely reversible. So always, when you have pure, this is the trick now. This is the trick. If you have pure lower motor neuron involvement in the motor picture with ALS picture, think about this pure motor variant of CIDP. Okay? The multifocal motor neuropathy with conduction block is another differential of this pure motor neuropathy, but again, both will respond to CIDP. From pure motor and up, all of those variants will respond nicely to IVIG and the sister medications. Okay? While the neuropacine antibody-mediated will not respond to IVIG, as you can see here. It rather respond to B-cell depletion therapy, like, for example, what do we have? Rituximab and Ocrevus, for example. Ocrevus is not used here, but it is the same. The patient logically will respond to this B-cell depletion therapy. The neuropacine antibody-mediated is usually severe and usually affect young population, not as that in the adult and middle-age population. Contactin 1 antibody-mediated is not fully understood now, and we have limited data for it. Now, what do we do for diagnosis? What do we do for diagnosis? The most important thing is to go back to what we have said just now, because you need to recognize that this pattern is suggestive of CIDP. Okay? And you should take history well, you should do examination well. Never ever in your life see a patient complaining of sensory or motor symptoms and you don't put hammer on his tendons. This is crime. Because if you didn't do this, Dr. Sohail will laugh at you when he received the patient with lower motor neuron as referral as a possible stroke. Okay, so this is very, very important. This is not luxury. This is not luxury, and the coming is very, very important. That was for the juniors, and the coming is for the seniors. Take home message for the seniors. Please lower your threshold on nerve conduction and EMG. Don't say, okay, this is clear-cut diabetic neuropathy clinically. I wouldn't refer the patient to nerve conduction EMG. There is very good study labeled the usefulness of electrodiagnostic studies in the diagnosis and management of neuromuscular disorders, just published in 2018. They studied 14 patients, 1,400 plus patients, done by Lindstrom and colleagues. They found, concentrate please, leave everything and concentrate. They found 52% of the patients, more than half of the patients, referred to nerve conduction EMG. Nerve conduction EMG changed the diagnosis. Changed the diagnosis. And this is very serious. You are thinking about something on the right, and the patient is suffering from something else. And this was not confirmed without doing nerve conduction EMG. The diagnosis has been confirmed by 47%, but more important, that they found that 63% of patients had change in patient management after nerve conduction and EMG. Okay? So what are we looking in for the electrodiagnostic study? What are we looking in the nerve conduction EMG? We are looking for demyelinating picture, okay? Slow. Delayed latency, slow conduction velocity, delay or absence of F waves. This is delayed responses. Conduction block, again, a pattern which reflects slowness. Temporal dispersion, another slowness pattern. And after EMG, we are looking for confirmation for this with low recruitment or probably secondary axonal findings on the EMG. This is the diagnostic criteria from the European guidelines, which is applicable now for every neurophysiologist everywhere. And probably you don't need to remember this all, because I really don't remember this all. But it has the basics of neurophysiological test. Definite CIDP, you have two areas of involvement with severe involvement, more than 50%, more than 30% with confirmation, etc. Okay? The possible CIDP, you have this significant severe involvement, but in one nerve. In between them, probable CIDP, you have less involvement with two areas. Okay? Lumbar puncture is important when you are in doubt. Not always done. Okay? It will show you the cytoalbumin dissociation. This means that, again, this is for juniors. If you remember this terminology, cytoalbumin dissociation, the albumin will be high, the protein will be high, the cells will be low or normal. The count more than 10 makes CIDP in doubt. Okay? The labs are not important at all to diagnose CIDP. Labs are done only when you are suspect something else. Suspecting diabetes, suspecting Lyme disease, suspecting HIV, you need to evaluate for sarcoid, etc., etc. And this is a really huge list of differential diagnosis. Now, the ultrasound can help. And this is neurophysiological ultrasound is emerging significantly. And you can see here, I don't know whether you can you hear me now? My sound's okay? Okay. So you can see here that in this side, okay. You can see that the CIDP was what? you can see that the CIDP, the Charcot-Marie-Tooth, the gammopathy, okay, are lying on this side. What is this side? This when you see the nerve swollen, big, more than double. And you can see that regional or diffuse, mild normal, okay? In ALS, you will see normal thickness of the nerve. In axonal neuropathy, you will see mild or normal thickness of the nerve. In GBS, you will see mild thickness. Charcot-Marie-Tooth type 2, you'll see mild thickness. The only way, this has been published in 2018. The only way to differentiate sometimes between CIDP and others is just doing radiological study, ultrasound, neurophysiological ultrasound. You are confused, you don't know what's going on, and you just see that this nerve is very swollen and is following a pattern of clinical pattern of CIDP, so this is most likely CIDP, okay? And you can see that CIDP, Charcot-Marie-Tooth, gammopathies are characteristic of demyelination and remyelination. So you have the thickness and the onion bulb, which has been seen. The other thing is the MRI. What are you looking in the MRI? In the MRI, you are looking for enhancement and enlargement. For example, when we spoke about the preganglionic CIDP pattern, we need to document the enlargement. If we saw significantly enlarged and enhanced, so we are thinking about CIDP or infiltrative process, nothing more than this. And do lumbar puncture after this. This will help you if the protein is high. And after this, also you can do nerve biopsy. Don't worry about the nerve. Don't say this is motor nerve, will not heal. Peripheral nerves heal. Neurosurgeon can stick a knife and take a biopsy and suture the involved root and give you an answer immediately, no problem. Peripheral nerves are not like central nerves. And MRI is part of European guidelines also, if you have problem, okay? The therapy, now we are closing. The therapy, the first line therapy is steroid, plasma exchange, and IVIG. The randomized control trials showed that all those three have the same efficacy. Steroid, IVIG, and plasma exchange. But the difference is in complication, availability, and cost. Now, what about IVIG? IVIG is very beneficial. Studies are showing that more than 80% will have complete response. 15% of patients might have very short course of IVIG, 1 or 2 IVIG, and they will recover completely, even if they are CIDP. The other remaining patients might have might need recurrent IVIG. Complications of IVIG are usually very, very simple. Usually headache, flushing, tremor, fatigue, chills, and diarrhea. But acute renal failure, thrombotic events, and hemolysis are reported, but they are extremely rare. Now, plasma exchange is an alternative of IVIG. What can limit plasma exchange? It's the same efficacy, but the limitation of plasma exchange is really because it needs dedicated center. You cannot do it anywhere. You cannot just do plasma exchange, okay? And the problem here, always remember this, CIDP with autonomic dysfunction, think twice before you do plasma exchange, okay? Now, this is very important. This is very new. Probably some of you did not hear about it. The subcutaneous immunoglobulin has been approved in 2018 to be a treatment for CIDP. Sub-Q IVIG is very easy to use. It is the same efficacy of IVIG. The patient will respond like IVIG without any problem. He will have better tolerability and has very rare thromboembolic and acute renal failure and anaphylaxis complications. But be careful, it is not approved as take-off therapy. It is a continuation. Always start with the IVIG, plasma exchange, or steroid, and then sub-Q IVIG can carry on later on and give you a very good result. Now, for refractory cases, those 10% of cases, remember the paranodal antibodies? Okay, so 10% of CIDP at least are refractory. Diagnosis, first of all, you should think about it again and again. Is it from the beginning CIDP? Probably it's not CIDP, okay? Another thing, think about the nodal and paranodal antibodies, because nodal and paranodal antibodies respond to rituximab significantly, not to IVIG. IVIG, this 10% patients will have zero response to IVIG. Okay? So whenever you have refractory, consider rituximab. We have alternatives, cyclosporine, methotrexate, cyclophosphamide are also used for refractory, but probably the rituximab is taken over. There's a very good randomized trial running now. It has been planned to end on December 2021, but the COVID-19 issue delayed the results. Okay, so it tested the rituximab to confirm the effect, but we have clear evidence that rituximab is working significantly. Now, what we do in pregnancy, we do the same. Okay, nothing to change. IVIG is safe, steroid is safe, plasma exchange is safe in pregnancy. What can we do in acute infection? Try to delay the beginning of the treatment, but if you are on treatment, continue on it. Okay? What you do in perioperative issues? Try to avoid neuromuscular blocking agents. There are some reports that after succinylcholine as anesthesia, we have some significant complications with CIDP patients, delay extubation and exacerbation of CIDP. Now, what about the prognosis? We'll conclude here. The prognosis of CIDP can be subdivided into main three categories. The first category is monophasic, single bout, lasting several months, and full spontaneous recovery. The other subtype is relapsing subtype. The third subtype is chronic progressive, worsening and worsening and worsening. Okay, but when to stop the medications? This is very important question, and we'll end with this answer of this question. Treatment should be continued until